Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 480 of our pharmacotherapy series, which majors in hematopoietic cell transplantation. In this video we discuss patient MPC from parts 478 and 479 of this pharmacotherapy series. In the third week post-transplant, MPC experiences a pruritic rash on his shoulders and neck, which spreads to the palms of his hands and looks like a sunburn. On day positive 19, the suspicion of acute skin graft versus host disease is confirmed by biopsy. On the same day, MPC develops diarrhea, losing 1,000 milliliters over 24 hours, and is noted to have a bilirubin of 2.8 milligrams per deciliter. He is started on methylprednisolone 1 milligram per kilogram IV every 12 hours. So my next question to you reads: what is the rationale for methylprednisolone therapy in MPC? Preventing the development of acute graft versus host disease is the most effective way to treat this hematopoietic cell transplantation complication. In patients who develop acute graft versus host disease, first-line treatment is a corticosteroid added to their current immune suppression regimen. For this reason, acute graft versus host disease and its treatment cause profound immunodeficiency. The combination of acute graft versus host disease and infectious complications is the leading cause of mortality for allogeneic hematopoietic cell transplantation patients. The route of corticosteroid administration is determined by the severity of the acute graft versus host disease. Those patients with only skin involvement of less than 50% of their body surface area may be treated with topical steroid creams, whereas involvement of other organs, or stage 3 or 4 skin disease, requires systemic corticosteroids. A complete response occurs in up to 25% to 40% of patients, with a lower likelihood of response in more severe cases of acute graft versus host disease. Patients with mild to moderate, that is grades 1 to 3, acute graft versus host disease who respond to initial therapy have a significantly better survival advantage than patients with severe acute graft versus host disease who do not respond to initial therapy. Patients who do not respond to corticosteroid therapy or have ongoing severe graft versus host disease usually die from a combination of graft versus host disease and infectious complications. Corticosteroids used in the treatment of acute graft versus host disease are generally tapered based on response. There is no consensus on the optimal method for tapering the corticosteroids, and the tapering rate depends on the patient. Patients who experience acute graft versus host disease or who experience flares of existing graft versus host disease during a tapering trial will have their dosages increased or tapered more slowly as tolerated. Because MPC had objective evidence of established acute graft versus host disease, he was given systemic IV corticosteroids. This was appropriate because single-agent corticosteroids are considered the therapy of choice for established acute graft versus host disease. Corticosteroids indirectly halt the progression of immune-mediated destruction of host tissues by blocking macrophage-derived interleukin-1 secretion. Interleukin-1 is a primary stimulus for helper T cell-induced secretion of IL-2, which in turn is responsible for stimulating proliferation of cytotoxic T lymphocytes. The recommended dosage of methylprednisolone for the treatment of established acute graft versus host disease is 1 to 2 mg per kilogram per day, given intravenously or orally in divided doses, followed by a tapering schedule that is determined by response. Trials that compared higher doses of corticosteroids, i.e., 10 mg per kilogram per day, to 2 mg per kilogram per day as initial treatment of acute graft versus host disease showed no advantage. Monitoring for rash, diarrhea, and bilirubin levels to assess acute graft versus host disease response should occur daily. MPC was receiving cyclosporine for graft versus host disease prophylaxis at the time the acute graft versus host disease developed. Although the cyclosporine was not effective in preventing the acute graft versus host disease, it is typical for patients to remain on the prophylactic immune suppressants. A significant portion of patients do not respond to corticosteroids, and they are said to have steroid-refractory graft versus host disease. If acute graft versus host disease symptoms worsen during 3 days of treatment and if the skin does not improve by 5 days, it is unlikely that a response will be achieved in a timely manner, and secondary therapy should be considered. Patients with steroid-refractory acute graft versus host disease have a poorer prognosis. A variety of medications are being studied for salvage or secondary therapy. The salvage therapy depends on the organs affected. For example, phototherapy is used as salvage therapy for skin graft versus host disease, and non-absorbable corticosteroids are used for gastrointestinal graft versus host disease. Other options for salvage therapy include anti-thymocyte globulin, denileukin diftitox, and TNF-alpha blockers, e.g., infliximab, etanercept. The most effective dose, timing, or combination of these salvage therapies is still unknown. MPC should be evaluated for response to methylprednisolone after 4 to 7 days. If his acute graft versus host disease has improved or stabilized, he should be continued on therapy at this dose for a total of 14 days. If MPC responds to therapy, his methylprednisolone dose should be tapered slowly over a minimum of 1 month, and he should be monitored for any evidence of recurrent graft versus host disease. If the graft versus host disease flares during his steroid taper as evidenced by worsening skin reactions, increased bilirubin, or increased diarrhea volume, the dose should be increased again until his disease is stable. The subsequent taper should be initiated at a slower rate. If MPC fails to respond to first-line therapy with methylprednisolone, he should receive salvage therapy. MPC was successfully treated for his acute graft versus host disease, is no longer taking corticosteroids, and is currently tapering off his cyclosporine. On day positive 200, MPC comes to clinic for follow-up after a 2-week vacation in Florida. On examination, MPC is found to have a mild skin rash on his arms and legs, hyperpigmentation of the tissue surrounding the eyes, and white plaque-like lesions in his mouth. He is also complaining of dry eyes. Laboratory tests reveal an increased alkaline phosphates and total bilirubin concentration. What is the most likely cause of MPC's findings? Chronic graft versus host disease, abbreviated as CGVHD, the most common late complication of allogeneic hematopoietic cell transplantation, occurs in 20% to 70% of patients surviving more than 100 days. Chronic graft versus host disease is a major cause of non-relapse morbidity and mortality. Risk factors for chronic graft versus host disease include recipient, donor, and transplant factors. Non-modifiable recipient risk factors include older age, certain diagnoses, e.g., chronic myeloid leukemia, and lack of a human leukocyte antigen-matched donor. Modifiable factors that may lower the risk of chronic graft versus host disease include selecting a younger donor, avoiding a multiparous female donor, using umbilical cord blood or a bone marrow graft rather than peripheral blood progenitor cell, and limiting the CD34+ and T-cell dose infused. Development of acute graft versus host disease is a major predictor of chronic graft versus host disease. 70% to 80% of those with grade 2 to 4 acute graft versus host disease go on to develop chronic graft versus host disease. Chronic graft versus host disease is not a continuation of acute graft versus host disease. Traditionally, the boundary between the two was based on time, but now they are classified based on different clinical symptoms. A consensus guideline for the diagnosis and scoring of chronic graft versus host disease has been published. The diagnosis of chronic graft versus host disease requires a. being distinct from acute graft versus host disease. b. having at least one diagnostic clinical sign of chronic graft versus host disease or at least one distinctive manifestation confirmed by pertinent biopsy or other relevant tests. And c. exclusion of other possible diagnoses. The clinical scoring system uses a numerical value of 0 to 3, with more severe symptoms having a higher number. A global score is calculated by including the number of organs involved and the severity within each affected organ. The global score reflects the expected effect of chronic graft versus host disease on the patient's performance status and can be used to evaluate whether treatment with systemic immunosuppression is required. The grading and prognosis of chronic graft versus host disease can define and predict high-risk patient groups. The signs and symptoms of chronic graft versus host disease in MPC include a rash in sun-exposed areas of the skin, hyperpigmentation of tissues surrounding his eyes, white plaque-like lesions in the mouth, dry mucous membranes, and increased alkaline phosphates and total bilirubin levels. These symptoms appeared after a period of complete resolution of acute graft versus host disease and during a taper of the cyclosporine. Thus, MPC has moderate involvement, quiescent chronic graft versus host disease. MPC is started on prednisone 1 mg per kilogram orally daily for the treatment of his chronic graft versus host disease. His cyclosporine taper is stopped, and the dosage is raised to therapeutic concentrations. So my questions to you read: is this therapy rational? What other agents are available to treat chronic graft versus host disease? There is no specific prophylactic therapy for chronic graft versus host disease, and the optimal treatment remains controversial. The mainstay of therapy for chronic graft versus host disease is long-term immunosuppressive therapy. Survival for patients with chronic graft versus host disease is improved by extended corticosteroid therapy, although there are multiple long-term adverse effects associated with the corticosteroids. A typical regimen is prednisone 1 mg per kilogram per day, administered orally in divided doses for 14 days and then converted slowly to alternate day therapy by increasing the on-day and decreasing the off-day dose until a total of 1 mg per kilogram per day on alternate days is administered. Alternate day therapy is preferred to minimize adrenocortical suppression. Once therapy is initiated, 1 to 2 months may pass before an improvement in clinical symptoms is noted. Therapy is usually continued for 9 to 12 months and then slowly tapered after signs and symptoms of chronic graft versus host disease have resolved. The median duration of treatment has been reported to be 23 months. If chronic graft versus host disease worsens during the tapering or after discontinuation of prednisone, immunosuppressive therapy is restarted. Other potential approaches for patients with refractory chronic graft versus host disease include mycophenolate mofetil, daclizumab, sirolimus, pentostatin, and extracorporeal photopheresis. When immunosuppressive therapy is administered for long periods, the patient must be monitored closely for chronic toxicity. Cushingoid effects, aseptic necrosis of the joints, and diabetes can develop with long-term corticosteroid use. Other severe complications include a high incidence of infection with encapsulated organisms and atypical pathogens such as Pneumocystis jirovecii pneumonia, CMV, and herpes zoster. It is reasonable to start MPC on single-agent prednisone for chronic graft versus host disease treatment at 1 mg per kilogram daily for 2 weeks and then convert to every other day as described. I would now like you to suggest some adjuvant therapies that should be instituted in a patient like MPC with chronic graft versus host disease. Patients who are being treated for chronic graft versus host disease should receive trimethoprim sulfamethoxazole for prophylaxis of Pneumocystis jirovecii and encapsulated organisms, such as Streptococcus pneumoniae and Haemophilus influenza. Ensuring optimal prophylactic antibiotics in chronic graft versus host disease patients is critical because infection is the primary cause of death during treatment. Artificial tears and saliva may improve lubrication and decrease the occurrence of cracking and fissures in mucous membranes. Newer therapies such as cyclosporine ophthalmic emulsion and autologous serum tears have provided relief for chronic ocular graft versus host disease. If nutritional intake is poor, consultation with a clinical nutritionist and use of oral nutritional supplementation may be advisable. Patients should be instructed to apply sunscreens to exposed areas whenever prolonged sun exposure is anticipated. Liver function abnormalities have been improved by up to 30% with the use of urodiol as bile acid displacement therapy. Calcium supplements, estrogen replacement, or other anti-osteoporosis agents should be considered in women or other patients at risk for fracture or bone loss while receiving prolonged regimens with immunosuppressant therapy. Patient education regarding the gradual resolution of symptoms such as skin sclerosis, fatigue and muscle weakness, anticipated duration of therapy, and importance of compliance with oral immunosuppressive therapy is essential. So there you have it, Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 481.